Evening. I'm Dr. Janet Pope, and on behalf of CME Outfitters, I'd like to welcome you to today's educational activity. So this is called Precision Medicine in Rheumatoid Arthritis, and we'll be looking at the evidence with biomarkers and looking at diagnosis and sustaining remission during de-escalation. We'll be talking more about biomarkers at the beginning. This program is supported by Bristol Myers Squibb. This CME activity is brought to you by CME Outfitters, as I said, and they're an award-winning, jointly accredited provider of continuing education for clinicians, actually all over the world. And we have people who are rheumatologists and other healthcare providers, so we welcome all of you. Also, you can follow them on Twitter, and you will be getting your credits claimed for various CME activities, and hopefully will be participating in this live discussion that we'll be having. So I am Dr. Janet Pope. I'm a professor of medicine and division head in rheumatology at Western University in London, Canada. And with me, I have very esteemed guests and colleagues and pretty good friends as well. So Dr. Roy Fleshman. Roy, do you mind introducing yourself?
Hi, everyone. So I'm a clinical professor of medicine at the University of Texas Southwestern Medical Center in Dallas and co-medical director of the Methotrexate Clinical Research Center in Dallas.
And tell us your expertise.
I have none.
He has many expertise, yes. So extraordinarily knowledgeable on multiple RCTs and RA and all sorts of other diseases. I also have with me Dr. Alan Gubowski, and he is both a lawyer and a rheumatologist. So he will keep us on the straight and narrow and telling things truthfully. But Alan, do you want to tell us about yourself?
Well, thank you, Janet. I'm professor of medicine at Weill Cornell Medicine. I'm an attending rheumatologist and co-director of our Clinic for Inflammatory Arthritis at Hospital for Special Surgery. And as you've indicated, my particular interests and areas of focus are inflammatory arthritis and also the regulatory aspects of rheumatic diseases.
And great to have all of us here. I think we're going to have a lot of fun, and we won't always agree, which is the best part, I think, of having a dialogue. So we will have 3 learning objectives, and we'll delve more into one or another depending on the audience questions and I guess the degree of agreement and controversy. So our first objective really is to look at the role of serologic biomarkers in both accurate and timely diagnosis of rheumatoid arthritis. We will also move on to applying treatment strategies and consider disease activity and serological biomarkers, again, in patients with rheumatoid arthritis. And our third one will be looking at methods of predicting sustained remission and a little bit on de-escalation of therapy. So let's dive in. So we will have some slides and mostly a lot of discussion, and I think it makes it far more interesting when we have a panel that is knowledgeable in this area, and we are always opinionated, as we should be. So we're going to really talk about biomarkers, and I think it's important that we're going to differentiate between biomarkers that we use every day in clinical practice and then proposed or emerging biomarkers. But before we get to that, I'm going to ask you some questions, and then we are going to define biomarkers for you. So I'd like you to think of voting on this question, and there might or might not be a right answer, but there will be different opinions on this. So which one of the following biomarkers is not among those commonly used in clinical practice? So the ACPA, which is the antibody against citrullinated peptides, the anti-MCV, which is an anti-mutated citrullinated vimentin antibody, the CRP or C-reactive protein, and the ESR or erythrocyte sedimentation rate. So many people are voting. We're going to let a few more people vote, and then we'll see what you said. Now, some of this you might vote because of lack of access, or some you might say, well, I don't think that's ready for prime time yet. So we'll see what you vote very shortly. And we're just waiting. Thank you, those who have responded. We appreciate it. And I'm going to remind people that they're in the Q&A, you can ask questions because in real time, we might be answering some of them as we get into our discussion shortly. Okay, so this is great. So I hope you're all seeing. So the probable right answer is the anti-MCV. You've probably heard of Vimentum, and it is one of the citrulline peptide proteins. And not everyone has access anymore to ESR, so I wondered if people were going to pick it for that reason. ACPA is indeed something we use, and you might be saying, well, it's not a biomarker because I don't follow it, but it can be used at the beginning. CRP, no one really chose that too much, that as not being a biomarker. It's related to increased joint damage, increased joint disease activity, etc. So great job. So Alan, do you mind telling us from a lawyer and a rheumatologist and a regulatory perspective, what is a biomarker?
Sure. Well, as Humpty Dumpty said, when I use a word, it means exactly what I say it does, nothing more and nothing less. So I thought it would be useful to begin our discussion, as you pointed out, with a definition that we can all somewhat agree upon. And the best definition I was able to come up with is the definition that the United States FDA uses, which is that a biomarker is a defined characteristic that is measured as an indicator of normal biologic processes or pathologic processes or responses to an exposure or intervention, including therapeutic interventions. It's broad and narrow at the same time. And examples of biomarkers, including some that we don't always bring to mind, are that these can be molecular, which are the more common. These can be histologic, these can be radiographic or physiologic, depending upon what it is that we're looking at. Now, it's also important to keep in mind that there are different categories of biomarkers, and biomarkers therefore can be used, as we're going to be alluding to throughout this discussion, to assess response to therapy, to monitor for adverse effects, as markers of safety, as diagnostic markers, as markers of risk and susceptibility. And they can also be used in both a prognostic and predictive fashion. And I think our discussion is going to take the 30,000-foot view and really hone it down on to what extent are they useful, not just in a cohort, but to the individual patient that is in front of you during the clinical encounter.
I think that you've nailed it on. It's both being narrow as well as being can be quite broad, and where we're probably going to discuss. And so I guess just a quick question. So if I have a patient who's 85 and ACPA negative, would that be a biomarker that ACPA is negative, she has RA and she's elderly? Would that be enough to say there's a biomarker going on?
Well, there is a biomarker. In that particular instance, the biomarker is negative, but the disease is present. So you have a disconnect between the biomarker and the disease. And it's going to depend what you're going to be using that biomarker for. Are you going to be using it to define therapy? Are you going to be using it to define disease? So we always have to ask not just, is there a biomarker, but what are you going to do if the biomarker is present? And what are you going to do if the biomarker is absent? In that patient, Janet, who's 85 years old, unless she's presenting to you for the first time, my strong guess would be that probably at one point in time, she was seropositive, and maybe we'll discuss what that means in a few minutes. And then she may have converted to seronegative. And then you have the other observation, which is particularly early in the course of disease. Patients may be seronegative for the biomarker, only to convert to seropositive. So the first problem that we have to keep in mind when we're considering the utilization of a biomarker, both in the context of your patient and in the context of all of our patients, is the sensitivity and specificity of the biomarker, as well as a possibility that the biomarker may have gone from present to absent or from absent to present in a, particularly when we use these biomarkers in a binary fashion.
Yeah, but Alan, how often does an ACPA go positive to negative? Certainly it can go negative to positive.
Yeah.
But positive to negative.
Yeah, you're right, Roy. That's unusual. Our knowledge of seroconversion is really predicated on the older data using the rheumatoid factor, where in those instances, seroconversion was prevalent in what we used to refer to as burned out rheumatoid arthritis. But you're absolutely right. It's less so in the ACPA. And another thing we have to keep in mind when we use the term ACPA is we're not probably measuring just one thing. We may be measuring several things with the same assays. There may be several anti-citrulline proteins that antibodies have been made against, one of which may be negative, another of which may remain positive.
Yes, that's an important point. So that's a panel. But I want to go back into what you said. So in terms of a biomarker, and Janet picked up ACPA, right? An 85-year-old patient who presents to me for the first time with 6 months of tender swollen joints and is ACPA negative, that to me is a prognostic biomarker. How would you use that biomarker? And the fact the fact that it's negative would tell me that she's less likely to have more aggressive disease down the road. Now, I don't know how much time there is going to be down the road when she's 85, right? But I think that the point that I would want to make is you have to use the biomarker correctly. What does it really tell you?
Exactly right, Roy. And I think the other thing that patient, if she's 85 and presenting de novo, is that we're going to be using that biomarker to assist in, well, I'll use the term diagnosis, but what I mean is classification. We have classification criteria, which are different from diagnostic criteria, and yet we all use the classification criteria diagnostic. We shouldn't. Time doesn't let us get into that difference, but for that patient, or for any patient, we now recognize since 2010 that there are 4 domains that can be assessed in defining whether or not that patient meets the classification criteria. And one of those 4 domains is, of course, the presence or absence of the biomarker you've just alluded to. So with that patient, we will initially use the biomarker for assistance in making the diagnosis. And then after the diagnosis has been made, even without that biomarker being positive, we will use it, as you correctly point out, in therapeutic selection and also in prognosis.
I'm not so sure about therapeutic selection. You may, but you made a very important point: classification criteria and diagnostic criteria. So the 2010 ACR-EULAR classification criteria were actually developed to get a relatively homogeneous group of patients into clinical trials. That's what it was there for, right?
Correct.
But for diagnosis, as Janet alluded to, right, I think quite correctly, patient's 85 years old, the patient has tender and swollen joints, may have some erosions, and whether they're seropositive or seronegative doesn't make a lot of difference because she's sure the patient has rheumatoid arthritis for diagnosis, right?
Yeah, it's not going to make a difference, but I dare say that many of us will get the rheumatoid factor and the ACPA anyway, even though she may meet the classification criteria, pseudo-diagnostic criteria by the other 3 domains.
Yeah, and you would for prognosis.
Right.
But now we have the slide up, actually, right? So Janet, what do you want to say about the slide?
Right. So first of all, I am enjoying our conversation. So I picked her really old so that to be clear that I still believe she had RA as opposed to pseudo gout or gout. So number one, I thought she had RA, and I made her a negative ACPA because age is a predictor of how someone will do. She's not going to be around 20 years. We want to keep her functional, but age might not be a biomarker, but the absence of ACPA might be helpful on various things. The other thing before we talk about the classification criteria, you've alluded to one way and agreeing, sort of disagreeing as well, about seroconversion. And I think an important item that we talk about is most patients who are strongly positive stay there. And patients with borderline positive might dip into negative. And certainly in early rheumatoid arthritis, the early RA, a North American cohort, in Canada, the CATCH cohort, about 15% of patients will seroconvert, about half going from borderline positive to negative, and about half going from positive the other way around. So hardly anyone would go from an ACPA RF of 200 to negative, or vice versa. So seroconversion in strong positives is unlikely. Then when we're getting into the classification criteria, I think it's always important to say classification and diagnostic should be really close, or else what are we doing? We just don't use them. So although they're called classification, we tend to operationalize all these criteria, the new lupus ones, the current older RA ones that use the new technology of adding points. We tend to use them as, I call this person, I label them, and yes, indeed, they meet classification criteria, but I'm making the diagnosis. So again, from an audience perspective, I think you're very familiar. If you treat or follow patients with rheumatoid arthritis, you score more points if you're having small joints, MCPs and PIPs. If you have a lot of joints, especially small ones, you're scoring more points. You pick the largest in each area. And seropositivity scores, especially a strongly seropositive, which is either RF, which is not as specific, and we'll talk about that, or ACPA. Then you have to have chronic disease in order to have a chronic disease. So symptom duration under 6 weeks, I still might label a patient with RA, say ACPA strongly positive, and for 2 weeks they've had these tender and swollen joints witnessed. I might get on with treatment, and it's highly likely they'll have RA, but you don't have a chronic disease till 6 weeks or more, which is same as what the old criteria showed. And then looking at acute phase reactants, and the audience very aptly said, oh, I think acute phase reactants can be a biomarker as well. Most people said they could be, even though you might not have access on all of them.
Well, Janet, let me interrupt you for 1 second.
Yes, please do.
About something you just said. The old criteria, the 87 criteria, required that the patient's symptoms be present for at least 6 weeks before you could make a call of rheumatoid arthritis. The 2010 criteria do not. And just as you can make a call of RA, again, we're making a diagnostic call using classification criteria and all the warts that implies. But the 2010 criteria allow you to call that patient at 2 weeks, at 2 days, if the other criteria are, the other domains are met. And one other point, the reason that you were able to say with certainty was that your 85-year-old patient did not have gout or pseudo gout, was that the other thing that these classification criteria require is that there is no other explanation for the patient's symptoms. Now, of course, crystal deposition disease can coexist, but you, in seeing this patient, have already determined that no other explanation exists. Hence, you now apply the diagnostic classification criteria.
Yeah, so I want to make one other point about that slide, and that is the difference between the 1987 and the 2010 is the 2010 actually allows you to make the diagnosis earlier, as you alluded to, Ivo. And I think that for the audience, what's really key here is there are 4 components. It's the joints and the number of joints. It's seropositivity or not. It's acute phase reactants, and it's disease duration. And so you certainly can have disease in less than 6 weeks if you have 20 tender and swollen joints, and they're seropositive, and they have a high ESR or high CRP.
Yeah, the other thing that
I want to ask one other question, and Janet, you've alluded to this. So why can't people obtain an ESR?
Oh, because an ESR for reimbursement is very low, but for lab tech time, they set up their column and put their timer on, come back in an hour. So it's because of the lack of automation, they're doing their column. The reimbursement isn't as appropriate as it could or should be. So some labs have stopped doing it. They go, we don't need it. It's old fashioned. You got a CRP.
Yeah, I was surprised to hear that as well.
So that's problematic, right? And the reason why it's problematic is 80% of people may have an elevated CRP and 80% may have an elevated ESR, right? But 99% will have one of the two. So if you're just doing a CRP, you could miss something. So just for the audience, in our lab, where we were certainly concerned about reimbursement, but we're really more concerned about taking care of a patient, we actually do both.
Yeah, you know, Janet, I have to agree with Roy. Even back in the old days, when the pyramid was still standing before we inverted it, when Roy and I trained, we were taught that if you were stranded on a desert island and all you had was a Bic pen, you could still do an ESR because of the ability to measure the fall of blood in a clear tube in an hour's time. So I'm surprised to hear that the ESR is not being done routinely in your part of the world.
Right, right. So I think, you know, it's good to call on that these things overlap, but not 100%, the acute phase reactants. And I think, Roy, when you were saying that they're up, obviously in active disease untreated, they're often elevated. Our partially treated patients, this is off topic, but it is a biomarker issue, is that if someone has active RA and say they're on optimal dosing methotrexate and partial responders, it's not sufficient to have inflammatory markers. You can have no inflammatory markers and still elevated and still have inflammatory disease that's active because of the fact they're partially treated.
You're absolutely right. So what I was referring to is a patient coming in, new patient, who's untreated, right? And in the untreated patient, 80% will have an ESR, 80% will have a CRP, but 99% will have one or the other. Once you treat, right? The reason why a lot of the audience picked ESR or CRP is it is a biomarker. The inflammation comes under control, although there are lots of other reasons, the elevation of CRP for the elevation of ESR, rather than just active disease. It's a pretty good biomarker for determining whether or not the inflammation is under control.
And let me just put a pin in that comment, Roy, and remind our listeners that there may be therapies that we use that may depress the CRP before we see the clinical response. And so we have to keep in mind that the suppression of a marker for inflammation may not mean that inflammation has in fact been suppressed.
Yeah, so let me put a nail into that, not a pin. So if you treat with an IL-6 inhibitor, or you treat with a JAK inhibitor, the chances of the CRP decreasing significantly, whether the patient has a response or not, is quite high, because an IL-6 inhibitor actually affects CRP. That's one of the reasons why, if you're using certain medications, it really makes no sense to calculate a DOS28 CRP, right, for that reason.
Well, we've put a nail in the horse, we put a pin in the horse, Janet. Maybe we should move on before the horse is dead. So the next
that's right. We're not killing any horses today. And again, generalizations in general are quite true. And you'll always find an exception to the rule, which is good. That's why we practice the art of medicine. So we're talking about biomarkers. We talked briefly about ACPA, but I'm going to turn it to rheumatoid factor because you have both alluded to that the sensitivity and specificity might change and the altering over time of positivity might change. So we're all aware that rheumatoid factor, so it's usually an IgM macromolecule that's directed against IgG. So all the right? So we're usually looking at IgM and IgG, but you can have a rheumatoid factor that isn't IgM. It can be IgE, as a for instance, pretty rare, but it's directed against the FC portion of an IgG. So that's why it's an autoantibody. It's directed against the FC of an autoantibody. So rheumatoid arthritis is, what we're talking about tonight. tonight, but other connective tissue diseases, vasculitis, cryoglobulinemia, JIA, even juvenile linear scleroderma can have an RF. Then as people age, RF goes up a little bit, about 5% of patients. We know certain infectious diseases, chronic hep C is for instance, hep B, endocarditis, some viral illnesses, and lots of other things, cryos that are associated with malignancy or not, mixed essential and other cryos, sarcoid, after a vaccination, you might have one, and some of these are transient. And I would say pretty rarely a malignancy, and in malignancy, we don't know why they'd be ordering an RF, I guess, if they're trying to figure out someone's sick and they don't know what's going on, but probably a physical exam would help for malignancy to rule out RA. But can I open it up to either of you? What do you think? Are you still using an RF? Word on the street is you're using it, and how are you using it?
So we are using it, and we're using it in association with the ACPA. So the ACPA is actually more sensitive and more specific. But there are patients who are ACPA negative. So if you take a look at clinical trial, the demographics in clinical trials, and you have 500 patients in a trial, you'll see that about 80% of them are seropositive usually. This is a Western Hemisphere population, but 80% will be seropositive for rheumatoid factor, but it's going to be 70% for the ACPA. So you don't want to miss those. And there are patients who are ACPA negative, but rheumatoid factor positive, and vice versa, double negative, double positive. So in my clinical practice, yes, I do both of them for the diagnostic criteria as well as for prognostic criteria. But I'm certainly, I certainly pay a little bit more attention to the ACPA than the rheumatoid factor, except for one thing that you mentioned. The highest rheumatoid factor I've ever seen was a patient who had what?
SBE.
SBE, absolutely.
And it was probably in the thousands.
It wasn't.
Tens of thousands, yeah. Yeah. So there are some great questions along these lines. So I'm not ignoring people's questions. Keep them coming. They're excellent. I will batch them up because sometimes we don't want to steal the thunder of other slides. But a question is, can ACPA positivity occur in other rheumatologic conditions the way RF does? Does anyone want to handle that question?
You know?
Roy, I think you've published on that.
So it can, right? But high positive ACPA is pretty diagnostic for rheumatoid arthritis. I can't think of many diseases in which you get positive ACPA. However, Dr. Kabowski and I listened to a grand rounds this morning, which was very interesting. It was Kevin Dean talking about pre-RA, and he pointed out something which we've been interested in years. You can get ACPA positivity way before you get rheumatoid arthritis. Years before, 10, 15 years before. And there are patients who are ACPA positive who never develop rheumatoid arthritis. Right? They're asymptomatic. And how do you find them? Well, you find, actually in Canada, they did the same thing they did in the US. They went back into veterans, right? They went back into veterans with serobanking, and they had positive ACPAs. And so I have seen several patients over the years. I've only been in practice for 3 months, so it's probably only about 200 or 300 who had a positive rheumatoid factor or a positive RA, positive ACPA, who had no disease. They had no systemic disease that I could tell. And for years, I couldn't find it. So it's not 100%.
Right.
Yeah, Roy is exactly right on that point. Just to wrap it up, you know, the presence of a rheumatoid factor does not rule in rheumatoid arthritis. The absence of a rheumatoid factor does not rule out rheumatoid arthritis. As he's pointed out, about 80% of patients may be rheumatoid factor positive and 20% negative. But it's the combination of the two that gives you a higher sensitivity and specificity for the real likelihood that the patient is either presenting in front of you with symptoms consistent with or likely to develop rheumatoid arthritis, which is a topic for another discussion. The whole area of preclinical disease is something that we can take on in another discussion.
Yep, and I think the bottom line is, so you can have ACPA, often low titer, that might be irrelevant, although not a ton of false positives. Also in other diseases that aren't RA, even GPA, Sjogren's syndrome, lupus, systemic sclerosis, where you can have ACPA, but almost all those patients have erosive arthritis. And you could say, well, are they just an overlap with RA, or is it the disease itself? And the right answer is, I don't know. But I sometimes say ACPA positive primary Sjogren's because I don't think they meet RA classification criteria yet or something. So I think all those things are a helpful way when we're thinking about these things to understand. Another question along this lines is, and I can answer it in the ERA cohort. So what percentage of patients are seronegative for early RA versus established RA? So I always thought, oh, when I had patients with RA established, 80% in contemporary cohorts, now it's about 75% are RF positive. In early rheumatoid arthritis from cohorts really in Western Europe, in the BRAS cohort, the Canadian cohort, Leiden, et cetera, it's about 60% are RF positive, 60% ACPA positive, overlap as well as underlap, and about 10% are to 20%, rarely 30%, I think, out of Ireland are double negatives. So there's a lot of overlap, but not full overlap. Whereas in an established group of patients, if you're looking at, say, an advanced therapy, you get about 75 to 80% are seropositive of active established RA 5 to 8 years disease duration. So are they different patients, and some of my patients get lost to follow up or go in remission? I'm not sure. I think they're the worst patients that need to go on to the advanced therapies because the trials are hard to get them in. They have to have all the criteria met for high inflammation, active disease, failing something, and seropositive or X-ray damage sometimes. I don't know your thoughts on that.
Well, Janet, as you've already pointed out, it's the early RA people that are more likely to seroconvert. So if you see the patient with early RA who meet the other criteria and they're seronegative, and you're telling us that in your cohort, a little over 60% of those might have been, I dare say that if you look at them a year or two later, you might pick up the other 11 or 12 or 15% that brings them up to that 80-20 that we've been talking about as the rule of thumb for rheumatoid factor.
Yeah, I think that's what Janet said, and I agree with that as well. And the rheumatoid factor, so it made the point the ACPA can be present for years before. The rheumatoid factor is usually not. Usually, the rheumatoid factor is usually more immediate, but it does increases over that first year or two or three. The ACPA, I think, is usually there.
Yeah, and we haven't studied this completely, but Roy, you've pointed out, as have others, that we think that smoking and periodontal disease are environmental factors, and they may be contributing to the conversion to seropositivity of rheumatoid factor after the genetic predisposition to ACPA is already present. So it may be that genetically you're predisposed to develop your ACPA, and then environmentally you develop your rheumatoid factor, and then 1 + 1 = 3 at some point where you get the clinical manifestations.
If you're unlucky enough to, as we said, some people hang on for years having no symptoms or arthralgias, but not necessarily synovitis. And we wouldn't call them RA until they have, I wouldn't at least, until they have either RA features. Maybe they have ILD, even some will have ACPA and ILD, but that is sort of a different way of thinking. So I'm going to shift gears because it's in this area. So I'm going to answer a question that was just recently put in. So the question is, if someone's a PCP and they're going to have primary care and they're going to refer, what biomarkers do you want? Do you want a bunch of tests? Do you want an ANA and an ENA and ANCAs and RF and CCP, or do you want none of it? So you're smiling, Alan. So what do you want to see?
Well, what I want to see is probably not what I'm going to get, because what I'm going to get is the LabCorp Request Arthritis panel, and it's going to give me some of the information I need, and it's going to give me a lot of extraneous information that I'm probably going to have to explain away at some point. But I think if you're asking me to rule in or rule out rheumatoid arthritis by the criteria that we've discussed, as opposed to ruling in or ruling out a collagen vascular disease in a patient with multiple symptoms, then really what all I'm going to want you to send me that patient with is the SED rate, the CRP and the rheumatoid factor, and the SED rate and the CRP.
Yeah, I don't want any of them actually. So if you remember the slide on the classification criteria, patient has to have one swollen joint. So if the patient comes in with a joint or with several or multiple swollen joints, and if the PCP isn't comfortable taking care of that patient and diagnosing the patient, I will see that patient with no laboratory tests. The other point is when you talk about the panels are done in different laboratories. And what we have found is that some of the laboratories are really good and some of the laboratories are not really good. So a lot of times we will repeat them to see what's accurate and what's not accurate. But I think that the reason for the referral is a patient for rheumatoid arthritis complaining of joint symptoms. Now,
Right, I have no doubt.
Dr. Gabowski is going to interrupt me and say that rheumatoid arthritis is a systemic inflammatory disease, but we recognize it by the joint symptoms. And we do look at the systemic inflammatory disease. Actually,
Dr. Gabowski was merely going to say, Roy, that with your 3 months of experience, I suspect you would be able to diagnose rheumatoid arthritis just with that one joint and without the laboratory.
No. So when I see one joint, the question is, what is that one joint? It's an inflammatory OA. Is it RA? Is it gout? Is it pseudo gout? Is it infection? I mean, it's that whole differential that we have. But but I can usually tell whether it's rheumatoid or not because it's usually not one joint. When it is one joint, it's more difficult. But the answer to the question is, I don't need a lot of laboratory. But if you do laboratory, and I would not send out a SED rate. We do the SED rate in our own lab because it has to be done in a very specific time. If you can do a CRP, that's fine. If you can do a rheumatoid factor, that's fine. I don't know why I get panels for ANA and anti-DNA and anti-SM and for anti-SCL70 for a patient who has one joint that the PCP thinks may have rheumatoid.
So Janet, we've had the appetizer. May I suggest we go on to the soup?
We can go on to the soup. I will make one final because I love doing it as the chair, that I always can agree with both of you, and I do. There's studies that say a positive lab is a trigger for the primary care making a referral because we don't teach everybody well enough to do a good joint exam. And although erosive OA to a rheumatologist is usually quite different than RA, when you're not thinking about joints all the time and the PIPs are quite swollen and you're not sure about MCPs, it is difficult. But I think the only other plug I'm going to say is do not do an ANA unless if you suspect a connective tissue disease, lupus, rash in the sun, bad Raynaud's, sores in the mouth, witness, because it will be positive and it will be the bane of your existence as the referring physician, because we'll say they don't have a disease and you're stuck with them again. So don't order an ANA as a biomarker or as a referral, because it might bite you. So let's go on, and we've got lots of great questions coming, and we will continue with them as well. So I'm just trying to find my place again. So I think, so we've really here, we've talked about classification criteria that we use as diagnostic as well in general and how to figure that out. We've talked about RF being not specific. And so I think we should just spend a couple minutes talking about this. So we've talked about what we're using in clinical practice, and there are some questions that I'm going to bring up shortly, but what do you think? Roy, pick one of these and either say good, bad, or ugly on one of the speculative ones.
Okay, so I'm going to do kind of what you said, but not exactly. So
Good.
we do a rheumatoid factor, we do an ACPA, we do a SED rate, and we do a CRP. Those are all quite useful. The second group, the anti-MCV, or the serum 1433 eta, or the anti-carbamylated proteins, and particularly the multi-biomarker disease activity test or the PRISM test, are really not endorsed by the ACR. And they're not endorsed by the ACR because it isn't clear what they really mean, right? Not yet, right? There is a study being done with the PRISM, which may turn out to be quite positive, right? It may become a useful biomarker for selecting a type of medication, right? It may be, but we don't know that yet. And, I've published 5-6 articles on the uselessness of the Vectra, but docs in the US like to do it because it's a test and they don't have to examine the patient, but it really doesn't have much clinical use that I can see. And the others are really, they're not really clinically validated where we can use them prospectively or for diagnosis. That's my 2 cents.
So
I
Janet,
think it's actually worth a Canadian dollar, which is probably about 5 cents. So Alan?
well, we call the Canadian dollar, do we still call the Canadian dollar a loonie for that reason?
It's a loonie,
a
yes.
loonie.
No,
As are sometimes the Canadians, but just usually our money.
I'm merely referring to the money.
We call it a dollarette. We call it a dollarette.
Dollarette, yes.
Okay.
It's a discounted dollar.
The dollar. So Janet, I was just going to point out that I agree with Roy. And I think my frame for the second bullet, and all the things under it, is that it's like the old Bob Dylan song, Ballad of a Thin Man. And the chorus is, you know that something's happening here, but you don't know what it is. Do you, Mr. Jones? So I think we have 5 or 6 things listed, and there may be some scientific validity to them. We're still being treated to papers about likelihood of response based on them for a given cohort of patient, difficult to translate to the individual. So I think, as Roy points out, these are not endorsed by the ACR, and as such, I think not yet ready for prime time in the context of an individual patient longitudinally. But I remain to be dissuaded by the science.
Yeah, so I think that's the correct statement. Let's see what the science really shows with all these. But I don't know that you can turn around and use this as a predictive biomarker that the patient's going to have bad disease, all right? Or as a biomarker quite yet that you can use X medication to treat the patient and they will respond.
Right. I think as well, timing, when tests are quite expensive, you're not going to do them every month, or you're going to do them when a patient phones in and says they're flaring, because we still have possibly a bit of telemedicine going on. Are you going to, is it added value to examining the patient? That's the problem. It's not like a continuous blood sugar read that now diabetics can have an ongoing blood sugar reading almost. This is something that would be discrete, a blood test, and then you have to interpret it. So there is quite.
So these tests, the only 2 that you might repeat, and probably will repeat, is the ESR and the CRP. There isn't much reason, once the rheumatoid factor is positive, to turn around and repeat it, or the ACPA, right? And the other tests, because I don't know really what they mean in terms of prognosis or diagnosis, if I do it once, why would I repeat it if I still don't know what it means?
Right. However, things like not ready for prime time, 1333 eta, MBDA, also known as Vectra, they do seem to change with disease activity, but maybe asking the patient and doing a physical exam also changes your thinking about disease activity. So that's the kind of thing the added value.
Janet, I have 5 publications in the MBDA where that is not true. You're seeing papers coming out from the company, right, with consultants to the company stating that. But when we've looked at JAK inhibitors, we looked at stimulatory molecules, we looked at TNF agents in trials, right? where the vector absolutely did not correlate with changes in disease activity.
And now you see why Roy walks around his car and looks under it with a mirror at night.
Well,
He doesn't do that, folks.
No, I don't. I just look at the data and report the data.
Okay, so you brought up something because this is a great question that's come up. So I was going to ask it later, but I'll bring it in here. So how often are the biomarkers used to include subjects in RA clinical trials? I know the answer, but if you want to bring it up.
None of the speculative, right? I haven't seen a trial with any of the speculative.
Right, but the other biomarkers that
But
you
the
need.
But the other biomarkers, it's quite, if you want to demonstrate inhibition of radiographic progression, they're going to ask for seropositivity, either rheumatoid factor or an ACPA, and they're going to ask for an elevated CRP. Why is CRP? Because that's a central laboratory, right? And they can do that. It could be an ASR or CRP, because patients who do have inflammation and are seropositive are more likely to erode.
Right.
Yeah, I would agree with Roy. In the context of clinical trial enrollment, usually all four of the ones used in practice are criteria for enrollment or for assessment of disease activity. The ones underneath are not.
Correct. And also you can't get your ACR or DOS response as easily if you don't start with a high inflammatory marker, of course. And we want to make sure they're classified as RA patients. And you want to look at erosions and things like that to see if these drugs can decrease progression of erosions. So we're going to move on. Again, the great questions, keep them coming. I haven't missed the questions. I'm trying to put them at the right time. So if you haven't been answered, your question yet hasn't been answered, we'll get there. So let's talk about applying treatment strategies, because there are questions too about, well, how do we consider disease activity with serological biomarkers in RA, or I guess, how do we or don't we? So looking here, here's what we're going to talk about, maybe treating to target, the ACR recommendations, disease measures, CDI, SDI, etc., how biomarkers help and where they help, and different drugs for RA treatment and when to use them. So I'm just going to briefly gloss over this because Boolean remission is closer to what we would think of as real remission. 1 or 0 swollen joints, tender joints, patient in global 1 or 0, CRP normal, so less than or equal to 1. CDI is adding tender swollen patient and physician global, and SDI is adding to that also a CRP. So, and Boolean remission for clinical trials might even be even stricter, but where the CRP is included. So these are some of the markers, and I think we might have more interest to the audience if I move on to the next slide. Roy, what are we talking about here on this important slide on metrics in RA?
Yeah, so this is very important in terms of treating the patient and treating to target and treating them to remission of low disease activity. So this is a post hoc analysis that I did from a study, and it's basically what we did was we looked at patients who had a response at week 24, which was either remission of low disease activity, and do they also have it at week 52, right? And we looked at various metrics. So it's hard for me to see the slide, but I know that we did the DOS28 ESR, which I think is the first bar. This is obviously a tofacitinib study. And the second is a DOS28 CRP. And you can see that there are many more patients achieving I think that's less than 2.6, achieving a DOS28 CRP less than 2.6 than a DOS28 ESR. So we never do a DOS28 CRP in the office because it's going to overestimate the disease control. And then the worst of the worst is the RAPID-3. So the RAPID-3 to me is a valuable tool because it's a patient-reported outcome. And we always take a look at the patient-reported outcomes, but only to do a RAPID-3 and say the patient's remission, this would tell me you're going to grossly overestimate. And then when you look at the bars on the left, we take a look at the DOS-28 CRP. I think that is actually remission, 2.6. ESR is much lower than CRP, DOS-28 CRP. And you can see the CDI and the SDI are very similar to the DOS-28 ESR, and the RAPID-3, again, is very high. So when you're examining the patient, you're doing a metric to see how the patient is doing, which you should. Dr. Grabowski has told me, I don't care what metric you use. I absolutely disagree with him. I do care what metric you use. It's the harder metric to reach because, as you correctly pointed out, Janet, the real remission, the real definition of remission is closest is the Boolean, right? And if we put Boolean in here, the bars would be even lower. But that's what you're really trying to get to if you can, right? So yeah, use it RAPID-3, give you some extra information, but don't use it to define remission. Don't do a DOS-28 CRP. You can do a DOS-28 ESR, CDI, SDI.
So let me put my comment that you cited in perspective, Roy, and that is that I'm a firm believer in the treat to target plan, which is use a metric and a target. And the reason I say I don't care what metric you're using, so long as you're using a metric, is that sadly, still 10 years later, only about 25% of our colleagues are using an objective metric to define whether or not their therapies are moving the needle. And we'll get to that in a few minutes. And that's why I've become a bit more acceptable to use a metric rather than use this metric, because if you're not using any metric, I've lost you entirely.
Yeah, so a lot of comments I can make to that, but none of them are politically correct, even for me, right? So I'm not going to make them. I am going to say it is important what metric you use. And the fact that many rheumatologists, many people taking care of rheumatic disease don't use a metric, it's shame on you. It's shame on you. And it doesn't take long to do it. I do a CDI and I do a hack. A hack is like a RAPID-3. It takes me less than a minute to do all that. It's much less than a minute. And then I have a number that I can use.
Right. So I think you're saying the bottom line is we need to measure. We should be treating to a target. What you measure, you're going to have a lot more people looking like they're doing well who are not in remission if you don't have a tight definition. There's a whole nother thing that we won't discuss here in any detail, but also if there's a discordance between what you think and how the patient feels, you're not going to treat active RA if the patient global is high because they have damage, they're waiting for a joint replacement as opposed to disease activity. So pain and patient global, we know, are very important on the patient perspective, but not always disease activity. Right.
So I want to very short vignette, which Dr. Grabowski knows. There's a metric called the Brooklyn Hack, a friend of ours who's in Brooklyn, which is how you doing, right? And that's actually a very important question to ask a patient. But I did have this example. Patient came in, right? And I said, how you doing? And they were doing great, right? That's what they told me, they're doing great. Hack was 0. They had 35 tended joints, 35 swollen joints. The ESR was, 55, whatever it was. And it said, I can't see you doing great. Why are you doing great? I won the lotto last night.
Absolutely.
So you have
Perspective.
Yeah, you have to take all of that into consideration.
That's right. So that we're amply at the time that, Roy, do you want to tell us about, because we're going to have an audience question soon. Tell me about this ample randomized trial. What are we looking at here because we're thinking it in terms of a biomarker?
Right. So the ample trial was done, I don't know, about 10 years ago. Originally, when abatacept was approved, the company said, it doesn't work as fast as the TNFs, but it's safer. But they actually did a trial, which is the ample trial, which is actually comparing abatacept to a TNF. And it turned out that the speed of response, the degree of response, degree of X-ray inhibition was exactly the same. You couldn't tell them apart. But one of the things we did in that trial was we did get baseline anti-CCPs. And then we looked at, did the anti-CCP differentiate, the titer, did it differentiate one drug from the next? So let's go to the next slide.
Roy, do you just want to, Roy, take a minute and define anti-CCP, because we've been using the term ACPA, and you might want to just define that for our listeners.
An anti-CCP is the same as an ACPA, right? It's an anti-citrullinated protein.
Yeah, so a class of which there's different CCPs,
Right.
1, 2, 3, etc.
1, 2, 3.
Yeah.
But it's basically the
Proteins-
same thing.
Yeah,
Yeah, they are. We'll consider that. So while I'm reading the question, feel free to vote. So this is test your knowledge kind of stuff. What was found at year 2 in the analysis of AMPLE-2, comparing baseline anti-CCP antibody status with clinical outcomes in patients treated with abatacept or adalimumab, and they were all on background methotrexate. So you're going to guess what was found. In both groups, anti-CCP antibody negative patients responded better than positive. Improvements in disease activity, disability, and remission were similar across all 4 quartiles of CCP positivity, from strongly to weakly positive. Improvements were numerically higher in quartile 4, the strongest, the highest ACPA for abatacept only, or improvements were numerically higher in quartile 3 and 4 for both abatacept and adalimumab compared to the quartiles 2 and 3. So we don't expect everyone to know the right answer, and this is something that I think is important when we're talking about biomarkers. So we'll see what people are thinking, because we have some responding, and we'll nudge a couple more to answer this, and then we're going to move on and get our results. Because a lot was made of this, that responsivity might be different between different drugs, and not might be, it is different between different drugs. Not all drugs have the differences. So good. So we've got a lot coming in. So we have interesting. So 1 in 6 of you, or 15% of you, said improvements were numerically higher in the quartile 4 for abatacept only. And that is the right answer. So I think we're going to have to explain this a little bit. So I'm going to just move on to the next slide here. Roy, do you mind telling us about what this is, what this means? This is a sub-analysis of the AMPLE trial that you described. So what are we seeing here?
Yeah, so what you see is you see abatacept on the left and adalimumab on the right. And what you're seeing is the different quartiles. The lowest quartile is the lowest titer of ACPA, and the 4th quartile is the highest titer. And that's the orange line. And what you can see is that 4th quartile on the left, that orange line, is lower than so this is the response, is more response versus adalimumab. And that's what we're seeing. So if the patients had low titer ACPA or negative ACPA, the response was okay. As the ACPA was increased, we got a little bit better response, very similar for abatacept and adalimumab for the 1st, 2nd, and 3rd quartile. But if you have high titer ACPA, then in this trial, and probably for even the practice, if you knew patient had a high titer ACPA, you might be better off using abatacept than adalimumab.
And certainly, as you say, there's been a systematic review of these quartiles are strongly positive, and strongly positive ACPA on the abatacept trials in the ones that had comparisons to either methotrexate, placebo, adalimumab. Always that strong ACPA gets a deeper response. So possibly more rapid, but certainly deeper.
Yeah.
So
yeah. One of the problems, but let me point out that one of the problems to it is in this trial, we were able to do all the titers. We could go up to 1 to 30,000 if we wanted to. But the commercial tests usually come back, higher than 1 to, higher than 400, right? They don't go to, you really can't tell how much ACPA is present on the commercial drugs presently.
But as Roy correctly pointed out and appropriately wrote, the AMPLE trial was really a seminal trial in that it began to get us to think about the possibility that there are differences in how patients respond to therapy, and optimization of therapy might be a function of the ACPA, and that it might help us identify the population of patients who are better treated with one agent over another, in this instance, abatacept over adalimumab in a population of patients. Indeed, our ACR recommendation, or ACR guideline, does allow us to use a non-TNF inhibitor as a first biologic, and that may turn out to be appropriate in a patient who is more ACPA positive than ACPA negative, and maybe reserve another class of agents as a first-line biologic or targeted synthetic for those that are not.
All right, so we got some great audience questions that is along this objective. So there's two, and one's a yin, one's a yang. They're coming about it in different ways. So how much is ACPA affected by medications like glucocorticoids, NSAIDs, and maybe the drugs? So in other words, you could look at it as response to therapy with an ACPA, or is ACPA attenuated when we treat? Does anyone want to answer either, like one way or the other, to interpret this question?
Yeah, I wouldn't even consider it. So I'm not looking to treat a blood test, right? So if I'm using glucocorticoid or a conventional synthetic or a TNF or a JAK, I don't care what it does to the ACPA. I care what it does to the patient. So we said before, I will do the ACPA at the beginning when I'm treating the patient, rheumatoid factor. I'm not going to do it a year later, 2 years later, 3 years later. Do I really care if it disappeared if the patient's doing well? Do I really care if it disappeared if the patient's not doing well? Right?
I mean, aspirationally, people do discuss this is not reality at this point in time, the way I practice or the way we practice, but aspirationally having a patient who is in clinical remission, radiographic, other imaging remission like ultrasound Doppler, and in serological remission might be our aspirational. But I fully agree that once the test is ordered and positive, I don't redo it. But that certain drugs I will decide to choose as a, for instance, we all know rituximab will have a deeper, better response in seropositive patients. And the trials we're looking especially at seropositive rheumatoid factor, but some of the similar data has certainly been found in exploratory analyses of ACPA positive. Ellen, anything to add? Oh, sorry, Roy.
Yeah, let me just. So the patients, it was rheumatoid factor. We published that. It was rheumatoid factor, not ACPA, right?
Right.
Is seronegative. The chances of responding is like 20%.
For a deep response, it's low.
Yeah. As opposed to the seropositive. Now, there was also a study that was just shown, I think it was at ACR, that there's also a little discrepancy with that with abatacept. The patient's seropositive, they will do better than if they're seronegative. But if you take a look at TNF agents or JAKs, there doesn't seem to be much of a difference. So seropositivity probably does play a role with certain drugs. I certainly think it's true with the Rituxan, and I certainly think it's true with ABA, but I don't know about the other drugs.
I think that's right, Janet, and I think what Roy says is entirely appropriate. We measure the ACPA and the rheumatoid factor at the outset. We really aren't measuring them throughout the course of disease because the response to therapy is less important serologically than it is clinically. And so it may give us some information early on about who will respond to what, perhaps as an initial agent, but after the initial agent choice of seropositive, seronegative, we're not going to repeat it as a function of trying to determine what the next agent is likely to be.
And let me remind you of one of the key points that you tell me. That's in a group of patients, but for the individual patient, you actually don't know.
Well, we have a group of learners with us tonight, Roy, so we have to give them the cohort, and the individual is a part of that cohort.
Yeah, But I do think it's important to say that what we're talking about is we are talking about a group of patients.
Right. We're talking about likelihoods in
Right.
populations rather than an individual. And that will be a problem that we're likely to get to in the next learning objective.
Which is a wonderful segue. So I think to summarize, some drugs we would profile particularly in a known on your chart, on your EMR, seropositive patients, but many drugs are worth a try in the looking at the order depending on what's going on. But in particular, rituximab and abatacept for the strongly seropositive, we're thinking of those more so than in strongly seronegative, but you can respond. It's just you're apt to not respond as well. So the next objective, really evaluating methods of predicting sustained remission following de-escalation of therapy. And there were some actual questions on this that I've saved for a while. So our objectives really, is de-escalation appropriate? If so, when? And how would a biomarker help? So first of all, before I open it up, because I think Alan's going to want to start answering this, the ACR says don't stop drugs that work. And if you're stopping drugs, stop the one that didn't work, not the one that did, when we're talking about advanced therapies. And EULAR says, well, maybe look at cost and you can consider lowering a dose of medication and the patient's still doing well, but follow them carefully. But that's my interpretation of the words, not the actual words. So Alan, what do you think here? Is this appropriate? And if yes, when?
Well, as you know, I'm not a great fan of de-escalation and heaven forbid stopping. I think that these strategies have been driven more by cost, although if you ask, they'll tell you safety. But you know, why? If you have a patient with hypertension who you get to the JNCV5 recommended systolic and diastolic, you don't stop their antihypertensive. And if you have a patient who's a diabetic that you get to the hemoglobin A1C that you've targeted, you don't stop their insulin. And I could give you multiple examples of even when you get the patient to target, you don't stop the therapy that got them there because it may still be doing something in a systemic disease. And that's what we forget, as Roy pointed out, that this is a systemic disease where we measure disease activity in the joints. So is de-escalation appropriate? It may be for some, but it's a strategy that I think needs a lot more work because we don't have good data on the long-term effects of de-escalation, let alone cessation of our current therapies. Do biomarkers help? Perhaps, but the real question is, what should we be looking at? And the answer is, you wouldn't even think about this, and the ACR doesn't even recommend thinking about it until your patient has been in sustained remission for not low disease activity, sustained remission for at least 6 months, and then maybe you can consider taking them off something. Why? Take them off the methotrexate. That's all the drugs we use, that's the one people hate the most. It's the one that didn't work, which is why we put them on a biologic. So biomarkers may help in terms of identifying when the patient is in sustained remission, but short of that, it's not a strategy that I tend to employ over the long term.
Yeah, and let me make a couple of points. The ACR guidance, which you just quoted, right, talks about remission, and they talk about Boolean remission or SDI remission. I want to be very specific. It's not a rapid 3 remission. So the question comes up in the clinic all the time. There are two people that bring up the question. One is the patient. Patient says, when can I stop these drugs? Or when can I slow down taking these drugs? And that's a very common question, particularly if the patient's doing well or they're having some side effects from the drug. The other is the question that I ask is when the patient really is in a sustained remission with no tendon joints and no swollen joints and normal acute phase reactants for a year or two, and then I wonder whether or not I'm over-treating them. So the question, how to do this is, so I will broach this to a patient, and there are many patients that say, Doc, you're nuts. I ain't broken. I don't need any fixing. I'm not stopping my drug. And that's actually probably a lot of patients. But there are patients that say, sure, how do I do it? And that really is more like the EULAR. So Euler talks about cost, and I guess cost is important, particularly in these times with extremely high inflation, right? Even in the U.S. But for the national health systems, cost is there. But as a practicing physician, ethically, I don't think of cost. I think of what's best for the patient. But we can move on to some slides.
Right. So we're going to do an audience question, and
Well,
I'll read.
Guibo already answered this one.
He did, but let's see what people say. So feel free to vote while we're discussing here. So which of the following is a predictor of sustained remission during therapy de-escalation, not stopping therapy, lowering dose, we'll call it as de-escalation, longer disease duration and treatment prior to de-escalation, deep sustained remission with the appropriate remission metric, moderate disease activity at the time of de-escalation, stopping versus tapering bio-DMARDs. So if you were listening, we'll get nearly 100% right. And I think there's two other things that you do bring up when we're talking about lowering dose. When a patient says, as a clinical pearl, when can I lower my methotrexate or when can I stop it? I usually ask, well, what are you taking now? Even though they told me they were taking as prescribed, because when people ask, they've usually already lowered their doses. So patients de-escalate without us knowing all the time. And then when they feel worse, they go back on things. That's very common. So just listen to what your patient's saying. And the other thing is we don't have not just long-term data on cardiovascular and other comorbidities. We don't have long-term X-ray data of someone in sustained remission who is now on half dose or, heaven forbid, no dose of medications. So anyway, let's look at our responses and we'll move on here because we've got lots of great questions. And again, we appreciate them coming in. So I think we can look at the responses and see where we're at on some answers. Great. So look at that. We got, you were listening very well. 2/3, well, 3/4 of you actually, that's what we were thinking about when we said this. Who wants to talk about this study here? This is looking at maintenance or tapering the AVERT trial in very early rheumatoid arthritis with poor prognostic factors.
Yeah.
Roy?
Yeah, so let me do this because this is actually my trial.
You got it. Yeah.
Yeah, listening to your author. So we did a trial which compared abatacept plus methotrexate to methotrexate. And if the patients were in SDI remission at the end of a year, then the patients were randomized into 3 groups. One of the groups was the patients continued the abatacept plus methotrexate, and that's the orange line. And the second group was they took the abatacept every other week, so it was tapered, plus methotrexate, and that's the light blue line. And they could take abatacept placebo with just methotrexate, which is the gray line, or they could take abatacept plus methotrexate. And what the results show is if you continue the abatacept plus methotrexate, a vast majority of patients maintain SDI remission. And if you stop the abatacept, patients didn't do quite as well. And if you tapered the abatacept every other week plus methotrexate, they were in the middle, right? So there really is pretty good data which says, yes, if you continue medication, you'll probably do quite well. About 50–60% of patients can actually taper the abatacept, but continue the methotrexate, but don't stop the abatacept. And about 50–60% of patients will remain in SDI remission. And then were in this study about 40% of patients who stopped the abatacept but continued the methotrexate were in remission. So the conclusion would be, if you're going to stop the drug that wasn't working, this would be the methotrexate, the gray line. It's best to continue, But if you want to taper, if the patient's been in a remission for a sustained period of time, it's going to work in about half the patients.
All right, so very helpful in illustrating those graphs. You can see over time what's happening, so very helpful. So the Arctic Rewind trial, looking here, this is de-escalation, but not stopping. So going from usual CSD MARDs, where patients are in remission, and randomizing them to staying on usual dose or going to half dose. So methotrexate, if you're on 25, you're randomized to 12.5. Sulfasalazine, you're on 3 grams, you're randomized to 1.5 grams or staying on 3, that kind of thing. And you can see here that everything is still in the CSD MARDs. If you cut down the dose, you still would have done better if you stayed on the stable dose. And so you can see here the risk difference is about 20%. So in other words, 80% of the time, half dose is good enough. 100 relative to the 100% of the time where stable dose is good enough as a risk difference. So I think that that's kind of telling even on our traditional or CSD MARDs. And then when we go to one of these other studies, this is Terra trial. This was a large RCT that was published and more data are coming from it over time. And everybody's in remission and you're randomized to either stopping your background DMARD, which would be often methotrexate, but it could have been various CSD MARDs, mostly methotrexate, or stopping your TNF inhibitor. So we have a lot of trials that are, you're on a TNF inhibitor and you're randomized to lowering the TNF or not, or stopping, lowering, or staying at the same. This is looking at the methotrexate side of the equation or other CSD MARDs or the TNF. And you can see in general here that some patients are going to have flaring, and the flaring seem to be the same, interestingly, in either group. So whether it's flare-free survival as you taper down one or the other, but not necessarily stopping, you get the same superimposed graph. So if you're going to look at cost savings, you'd maybe cut the TNF in half. If you're going to look at patient tolerability, maybe they'd say, I feel sick on the methotrexate, I'd like to go down on that. So and it doesn't matter whether you're looking at DOS remission, Boolean remission, HAC, flare-free survival, or the mean DAS over time. So I think that this is kind of telling that there are different things we can taper, because as I move on now to some of our discussion, we've got some great audience questions, but any comments?
Yeah,
Janet, comments, give me comments.
I want to make 2 comments. One is the Terra trial. As I remember it, is faulty. And the way that it's faulty is, yeah, the drugs would change the way you said, but if the patients began to flare, they were treated with intra-articular corticosteroids, lots of intra-articular corticosteroids. So it's hard to say whether or not this tapering the TNF versus tapering the conventional synthetic was actually really accurate. That's my personal opinion. But what's more important is when we talk about tapering drugs, what's very important for the audience to know is if the patient's in remission and the patient flares and you go back and give them the drug, not everybody gets into remission. And then we have to come back to Dr. Kabofsky's very important point. Rheumatoid arthritis is a systemic inflammatory disease. Patients who are untreated or inadequately treated have a high incidence of MACE. They have a high incidence of malignancy. They have a high incidence of VTEs. They have a high incidence of serious infections. And the key is to get the patient the best disease control you can, not only for the joints and not only for the comfort and for their function, but also for the systemic complications. And that's one of the reasons why, for me, if it ain't broke, I don't need to fix it.
Roy, I couldn't have said it better myself. Oh, wait, I did.
Yes, you did.
He did indeed. Yeah. So if I may, if you'll humor me a little bit, I want to do a couple rapid fire questions that are in this area. And I might pick on one or the other. It's not picking, I will, chair's prerogative, but the other can add if we want. So Alan, I'm going to start with you. When you say you're not concerned about cost, but it's any of us, but I'm going to just say, Alan, if we're not concerned about cost, how do we get around the insurance companies denying a medication? And if you appeal, is it also denied, and then what? So that would be on full dose before de-escalation. How do we get around it? I mean, the guidelines help us.
Well, I am concerned about cost, but I'm concerned about utilization cost, not acquisition cost. And what we're learning is that drugs that may be cheaper to buy may be more expensive to use, and drugs that are more expensive to buy may be cheaper to use. So when you talk about economic reductions, generally these studies only focus on direct costs of saving the price of a drug. It doesn't focus on things like, oh, I flared, I've got to go back to the doctor 4 times instead of twice. Oh, I've got to take 4 days off of work instead of 2. Oh, I've got to have my spouse or partner take a day off of work in order to accompany me. So the cost savings of direct costs are often overshadowed by the cost increase in terms of indirect costs. That said, how do you deal with denials? You got to keep pushing, but the patient has to push, because there is a mechanism of every managed cost company to have both internal review as well as external review. And if you've exhausted your internal review and you really think the patient needs to have something done, you've got to assist them in the external review of that state or municipality that is providing the oversight of that insurance company. In my experience, putting my other hat on, I've generally found that when the internal reviews have been exhausted, merely suggesting to the carrier that you're going to take the external review is enough to prompt another internal review, so you get what you want, or at least you get what you need, if you can't always get what you want.
Yeah, so I actually made the comment about cost, but let me clarify that. So when I'm taking care of a patient and giving the patient advice, I don't think about cost. I think about what do I think is best for the patient? What does the patient think is best for them? Right, that's your decision making, and that may be a drug that is not one that is preferred by the pharmacy benefit manager, right? But that's what I think of, right? And I think that's the only ethical way to do that. If I said, well, I'm going to give you the cheapest drug all the time, I think that that's problematic, at least in my ethics. Now, Dr. Grabowski has ethics, which if you don't like, he'll change them for you, but I won't change mine, right?
If you don't like my ethics, I have others.
I know.
No ethics are changing here.
But there's a second part of that, right? And that's what the person is asking. So you do that, and then how do you deal with it when the insurance carrier denies it, right? And I think that Dr. Grabowski answered that quite appropriately.
Right. So a question here, and this is a trial question. So Roy, I'm going to send it your way. And I might correct the answer, but I doubt I will, because you know the trials extremely well. There's a question on, well, what drugs do we have pretty good data on? I'm not going to say stopping therapy, but on de-escalation. So in RA, can you tell me the classes of drugs where we have pretty good data?
De-escalation of the drug itself or combinations?
Well, it's often of a drug and RCT. So in other words, if there are classes of drugs where half dose is as good as full dose in 60 to 85% of patients.
Yeah, so I'm not sure. I'm not sure about that. So there are many trials. There are many trials with de-escalation, and it does show that there are patients who can de-escalate. Instead of taking etanercept once every week, taking it every other week. Instead of taking adalimumab every other week, take it every third week. Rituximab, it doesn't have to be every 6 months. It might be every 8 months. And so individual patients respond to different drugs in different ways. And you can think about de-escalating by spreading out the interval. And I think there are lots of studies which show that. I don't know what you're thinking of.
Right,
Well,
right. I'm
Janet,
not,
we've had experiments of nature during the pandemic where patients had difficulty obtaining their medication or obtaining the medication in a timely fashion. And you would hear from some that they spread their dose out, they didn't stop, and they did fine. And you would hear from others that they spread their dose out and they tried spreading their dose out, but they couldn't.
Yeah, and that's
So,
the trial show.
absolutely. And fear as well. Like they
Yep.
were holding off at the beginning, not knowing what would happen if their drugs made them at high risk. I'm not sure. So one way I was wondering about this question is there's lots. So the TNF inhibitors, IL-6 have the most data on tapering therapy, the CSD-MARDs we showed you. We don't really have a randomized control trial of JAK de-escalation. And you have to remember it's fast on, fast off. And we don't have many trials on de-escalating drugs such as abatacept or looking at rituximab. And rituximab, we do have the very low dose. So there are trials where in general, until they're in remission on rituximab, I would use standard dosing. Once they're in remission, possibly because you want them to not have a bad COVID outcome, you want them to have a good response to vaccines. There's ultra low dose, low dose. So the maintenance or the retreatment dosing of rituximab can be all over the place. The ACR 70s or DOS remission, which is DOS less than 2.6, not full remission, are better in general on higher dose of rituximab until they're in remission. So that might be the question. I'm not sure.
There is data on abatacept, which I showed you about reducing the dose. The other point that I would think about would be you have a patient on combination. So all patients, not all patients, all groups of patients do better on combination therapy with advanced therapy plus methotrexate. There isn't a single exception to that. JAKs, IL-6, TNFs, ABA, rituximab, you need the combination. But there is data on monotherapy of these agents. And in monotherapy, certainly probably 60, 70% of patients on a JAK can go monotherapy if they're in remission on the combination, right? Not all of them, but many of them. And the IL-6 is probably pretty much the same. Maybe 50%, 60% go to monotherapy, not all of them. But with TNFs, it's pretty clear, with ABA, it's pretty clear. Monotherapy is not much better than methotrexate. So in terms of that type of stopping, there is a difference in terms of monotherapy versus combination therapy.
So Janet, I'm going to suggest that the three of us could probably go at this for a small symposium over the course of 2 weeks in a nice geographic location. But we're getting near the end, and maybe we should whet the appetite of our listeners to stay on for the after show once we do the closing remarks on this.
That's right, exactly. So first of all, I think this has been lively. I've learned things, and I hope and think the audience has as well. So part of CME, Adult Continuing Medical Education, is the SMART goals: specific, measurable, attainable, relevant, and timely. So that's SMART, in case if you're wondering. And you can see looking at autoantibodies can support diagnosis and classification of RA. Biomarkers can certainly predict prognosis in patients not adequately treated in particular. Reasons for tapering therapy may include less toxicity, but we're not trying to prevent severe toxicity down the road. There was a question about that. If a patient doesn't have a lot of side effects now, they probably won't in most cases later for many of our drugs, but less cost. But we want to have achieving sustainable remission and following them carefully if you're going to choose to taper. And it would be an individual decision, not always considering that. And use caution when de-escalating RA remission, because if they don't regain it, I think we're all pretty sad about that. So there's one question that I think is really important is if a primary care physician or nurse practitioner, et cetera, if a primary care refers, should they be referring everyone with truly suspected rheumatoid arthritis? One to 2 word answers, Alan?
Yes.
Roy?
Yes.
Me? Yes. Okay. Then there's one other provocative question as I move on here. This is how you can get your credit. A provocative question is, how do we truly know the patient's in remission? So if I'll answer quickly first, and then we'll just put in our 2 bits because we're about to end. I think it's a series of clinical and laboratory, or what we might call biomarker inflammation. And I don't always know, but I can say clinically, no tender joints, no swollen joints, MD global, which is based on labs and other things, 0. Patient global, they're doing great. From their RA perspective, they might be not feeling great on other comorbidity treatments, et cetera. And I would say lack of imaging progression over time. I'm not going to do a PET scan or something. Anyone else have a different answer as we close out?
I think you've summed it up very nicely, Janet.
But you also have to take a look at comorbid diseases. That has to be under control too. But the truth of the matter is you know, there is a Canadian rheumatologist who I think is really quite knowledgeable, Ed Keystone, who I think we all know, who says that if the patient doesn't have a swollen joint, the patient doesn't have an erosion. If the patient fulfills all your criteria, my guess is that the risk for comorbid diseases related to RA is really quite low. So I would agree with what you said.
Absolutely. Well, this has been wonderful. And there was a question on comorbidities, and I thought that's a great CME outfitters for another time. So comorbidities do affect remission, response to therapy, drug disposition, et cetera, and probably big time the affect adherence. So that's for another day. So I would really like to thank Alan and Roy, and I myself had a wonderful time. We thank CME outfitters. We hope you're going to fill out your eval to get your credits. And we thank you all and for attending, and please join others on these accredited CMEs. I find them really helpful for myself as well.